neurology clinic. This part a little bit hard to diagnose, and the title is Role of Multidisciplinary Team in Management for Central Nervous System Abnormalities. For central nervous system, the structure is complex and the diseases are varied, so it's not easy to find and even cannot be detected throughout all the pregnancy. Some malformations occur at later stage and intrauterine phenotype. And what's different with postnatal disease severity? What's for the prenatal diagnosis? What's the relationship between? For the phenotype depends. So for the neurologic disease, it's very difficult. So we need a multidisciplinary team to get the final diagnosis. This is how to scan for the fetal head from the top continues to the bottom. Transventricular, transcerebral, and the cerebellum for the axial, and also for the Doppler mobility stream. The technique for prenatal diagnosis has also advanced. From the beginning, we simply understood that human beings have 14 sex chromosomes, and then for fish, CGH, and Y's and SMP3. Now we can test the whole genome of all humans. For men's WGS, it's a new technique. This our hospital, the organization of prenatal diagnostic center. We have 3 groups. One group for clinical group, and the second laboratory group, and imaging group, including the obstetrician, fetal medicine, clinical, the genetics. And for laboratory group, we have cytogenetic, molecular, and biochemical immunity. And for the imaging, we have ultrasound screening diagnosis, and MRI, and X-ray. It's me. Yeah. To do the MDT, we need a big team to consulting. The following I will introduce some cases. The case 1, the pregnant woman was 31 years old and G1P0, came out of hospital at 28 weeks due to the abnormal ultrasound from other hospital. Ultrasound is a fetal intracranial structure with abnormalities, including the delayed development of the lateral cerebral fissure and parietal occipital suckers, and also the widening of bilateral ventricle. Left one is 12.1 millimeter, and the right is 10.9 millimeter, and also with polyhydramnios. So what's the suggestion for the pregnancy women? So we need assessment by ultrasonography again, fetal MR, and also to do the prenatal diagnosis, and near fluid puncture, and consultation. For the scan image, we can see the lateral ventricular wall is not smooth. This is normal and is not smooth, and the lateral fissure doesn't match your gestational age. And also, the parietal occipital sulcus is flat than normal. For MRI image, the fetal brain diameters was smaller, very smaller. It's very smaller, corresponding to the gestational age, and also it's small with the small suckers. This is normal, and this is abnormal. So, what can we consider the abnormalities? What's this disease for the baby? We can see abnormal neuronal migration. Do you agree? And listen carefully for the ultrasound diagnosis. So for the laboratory result, its absence guidance, growth restriction, and dysmorphic appearance. So what's the reason? It's caused maybe by gene mutations. So we do the laboratory, and we found deletions of the MISI, which can cause the lysencephaly. So, generalize the anomalies of the lysencephaly macrogyria is because the neuronal migrations. So, we are right for the prenatal diagnosis. And this reason, this development is usually at 9 to 13 weeks gestation. So the final diagnosis is Miller-Dieck syndrome. The Miller-Dieck syndrome, ultrasound doctor, MRI, molecular, and embryonic development. So for all the information, we can get the results. The clinical characteristics of the patients: growth retardation, severe psychomotor retardation, and angular reflection, and early death some patients. So MDT is very important to do the prenatal diagnosis. This case 2. The case 2 pregnant woman was 27 years old, J3P1. The pregnant woman, she requested to do prenatal diagnosis because the couple had a 6-year-old boy. The boy no fetal distress and neonatal fissure, but the boy with deafness and the severely developmental retardation. The boy MRI showed the polymicrogyrial malformation and white matter reduction, delayed myelination, and double frontal, the temporal parietal axial and carefully spaced. Both ventricles are irregular dilated for the boy MRI, And the boy metabolic test and CMV is negative. So what's the reason? The second baby in 23 weeks, ultrasound scan was normal. MRI showed the left cerebral hemisphere was slightly smaller than right, and the ganglion was smaller and shallower. The pre-parenchymal was thinner, and the cerebellum shows polymicro in ganglion. The baby. So we do the best. The fetus carried the JJB2 heterozygous, which inherited from the normal couple, and no other abnormalities were found. So the couple chose to terminate the pregnancy. So this is MR for the baby. So I introduced the family-wise result. The fetus carried gene mutation, both JJB2 and MMACHC, which inherited from normal parents. However, the result could not explain why the boy and the fetus showed polymicro ganglion both. So we went to the database for manual filtering, and we found the fetus carried ATP1A2 gene, the new gene, inherited from parents and can cause polymicro ganglion. And eventually, finally, the couple can use 3 pairs of gene also. So it's very complex for the family, for the gene mutation. So MDT, we have obstetric expert, a clinical genetic and genetic pediatric expert, medical imaging specialist. So a team is very important. For the case 3, the pregnant baby is 29 years old, and the baby is 23 weeks pregnant at G2P1. Doctor 3 years old, 3 years and a half years old, healthy. To our hospital is referred to fetus suspected ancestral cell. And 11 to 14 weeks and 23 weeks to do ultrasound. Ultrasound examination, no abnormalities. And also the doctor screening is low risk. The baby's hand, heart, abdomen, and kidney, mouth, blood, labs are normal. Everything's normal for the ultrasound we do. And measurement of the baby's the lungs of the fingers and the hand is normal. But we found, look at the video, but we found the parental skull defect, but it's symmetrical, left and right. The cyst about 0.9 centimeter and another one is 1.5 centimeter. And the 3D volume, we can see just the protrusion like a cyst. So what are thinking about? Do you think about? Is this? What's this disease? Manicacello? Do you agree or not?
Agree.
If you agree, raise your hand. No? So you disagree. But what's this? The characters called defective, but it's good. The latest century. This one, it's intact. So what do you think about? If you know, raise your hand. The big picture like this. Now, definite ensemble. So, in the folio, we got a detailed scan for the baby. The forehand hamper and the base of the nose collapsed. No? That feature suture. Current suture, you could find. No, that fitted the current suture. Oh, maybe this, yeah. Look at the baby. The suture, you can't find. So, what do you think about? But the baby's also overlapping toes. And no both hand, just the overlap of toes. Look at the baby. The hand is normal. Toes. What do you think about? But this big picture, we couldn't find the ensemble C. It's century located on the heritable. And for the toes, MRI. The MRI, the result is to show the bony defect at the top of the skull being meningocecal. Do you agree the result? Meningocecal? Do you agree? Raise your hand for the MRI. No. Articles for the CT. Reconstruction like this. It's symmetry, both left and right. We also do the gene amniocentesis. We found the gene is TWNST1 and the SAMTA-BP1. 2. New diagram. So which one's the better result? For the TWNST1, we can find some syndrome, maybe sensory chosen syndrome, and dominant sort of syndrome, or Sweeney-Copeland syndrome. The ultrasound findings and the appearance afterwards is different for the syndrome. For the same gene, no. So we do the genetic consulting. It's associated with cranial synostosis syndrome. Premature fusion of one or more sutures of the cambrium. So that's the result. And for the patient, for the baby, small auricle, the pruded. And for the legs, round whole legs, And for the intelligence, the gender is normal. And the real features, the parietal foramina. So that's the answer. For the cranial synostosis, usually the coronal suture is the most common affected. But some and all sutures can be affected. And often with the abnormal skull shape, like this case, and a family history of some individuals diagnosed with IC may appear to negative because failure to recognize the disorder of the family members. And each child has an individual with ICS and a 50% chance to inheriting the pathogenic variant. So prenatal testing for pregnancy and increase the risk and the pre-implantation genetic testing are possible if the pathogenic variety has been identified in the family. So for the cases, all the so the MDT is very important, very, very important. It's difficult for the case. The case 4 is 26 weeks. The baby's hand is normal, and the measurement of the BPD is normal because the 26 weeks is normal. But the FR and with the HC ratio is very low, 6%, just very lower, smaller. We can see the baby's the femur hand is very short, but the hand is normal. The big hand, narrow throat. The small and narrow thorax, shortened spine, and the bending and short femur, and the sinking metaphysis with high ankle here, and the flat face and nose bridge, the 3D picture, like this. Afterwards, the same with our 3D volume picture. Front we can see the flat face, bilateral ankle joint contraction. It's a semi-short lower for the legs. And the back, we can also see the short legs and sky-like skin change. X-ray, post-delivery X-ray, small and narrow thorax, and short legs. So MDT. Yes, for the X-ray, eccentric lower limers, punctate changes in the mitral facing here, different, and for here, and for laboratory, the best analysis for this case, we can see EBP mutation. And it's de novo. And the baby's parents are normal. So it's de novo for the baby. So the final diagnosis, what's the diagnosis? It's accident dominant cultural displays punctator. Punctator is also called CDPX2. It's very rarely cases. So MDT also important. Summary: the nervous system is very complex and also complex. So the phenotype drive and we need the genotype drive for the perinatal diagnosis, and different from other systematic. We need specialist clinician need to join and appropriate technology. For example, dynamic communication, and we should consider according to the different disease. According to the